today, which is about good morning, everybody. This activity is hosted and prepared by Prince Sultan Military Medical City in Riyadh, Kingdom, Saudi Arabia. Since the title talking about endocrine and metabolic aspect of COVID, just brief that this institution is a tertiary hospital, have been accepted all patients with COVID since we start seeing cases in Kingdom Saudi Arabia, admitting patients, whether eligible or ineligible to be treated in the hospital, admitting Saudi and non-Saudi population. We have a huge of patients when we started the COVID era. Alhamdulillah, now we are coming little down of the cases. Maybe we are the lowest among the whole group. This is because of a strict strategic plan have been done from the government of Saudi Arabia. Today, I would like to thank the Department of Academic Affairs and this institution, also Continuous Education Department, for arranging this activity. Today, the talk assigned by Endocrine and Diabetes Department. And I would like to present my colleague, Dr. Anjum Faris. She's a consultant endocrinologist and diabetologist. She's a fellow of Royal College of Physicians, Edinburgh, UK. She was seeing most of the patients who have been admitted to the hospital as other colleague from other department, mainly the internal medicine department. Today she'll talk about endocrine and metabolic aspect of COVID-19. Dr. Anjum, Zoom is yours.
Good morning, everyone. Assalamu alaikum. I'm Dr. Anjum from the Department of Endocrine and Diabetes, and today it's my pleasure to present in the hospital grand round. And my topic today will be endocrine and metabolic aspects of COVID-19 infection. And as we all know that we are still in the mid of a pandemic and by COVID-19, and we don't have much knowledge or much information about this virus, and still we are in a learning process, and we don't have high quality data that how exactly this virus affects the endocrine system. But we do have observational studies, retrospective studies, and some case reports which gives us some insight into the possible involvement of various endocrine glands during this COVID-19 infection. And patients who are in acute phase or in the convalescent phase can have various endocrine manifestations. Of this, we should be aware of as physicians so that we can pick up these patients' cases early and manage accordingly. So the outline of my talk is this, going from introduction, pathogenesis, and then I'll touch on all these topics in brief. And actually, the first part of my talk will be how exactly the various endocrine glands can be affected during COVID-19 infection. And if time permits, in the second part, I will try to focus on how exactly we should manage patients who are having pre-existing endocrine conditions and they get infected with COVID-19. As we know that SARS-CoV virus, it belongs to the beta genus of the coronavirus family. Actually, this is the 7th virus from this family which is causing the infection. And it's very important that this virus has 80% genetic sequence similarity with SARS-1. So we do have experience with the SARS-1 epidemic in 2002, and we can utilize that knowledge to get any information how exactly this virus affects the various endocrine system. So in brief about the pathogenesis of this virus, so we know that this virus enters through the respiratory tract and it binds to the epithelial cells, and this virus, it has a spike protein which is called the S protein. The S protein, it binds to the host cell through the ACE2 receptors. Actually, this S protein proteins. It has two parts, S1 and S2, and this S protein needs cleavage into S1 and S2, and this is being helped by some of the host factors like this protein here, transmembrane serine protease 2. This is, and also cathepsin. This helps in the cleavage of this S protein, and which facilitates the binding of this virus to the ACE2 and fusion of this virus, and then entry into the host cells, and then it replicates, and then we know how what it goes on. It replicates, and then there can be viremia, and then infection of various organs. So endocrine organs. So we know that all the endocrine organs, most of the endocrine organs, they have this, they express the ACE2 receptors. Most importantly, the thyroid gland, hypothalamus, pituitary, testes, pancreas, all these organs, they have high expression of these ACE2 receptors. So these organs can get affected either directly by the virus when there is a viremic phase, or indirectly when there is an systemic inflammatory response. So all these endocrine organs can get affected. So this is just an overview of how exactly all the organs can affected. In thyroid can get affected, acute thyroid, pituitary. We can have hypothalamus pituitary involvement leading to transient hypothalamic pituitary dysfunction, testicular involvement. We know there is a higher susceptibility and worse outcome in men. Low vitamin D is related to worse outcome, and also association with cytokine storm. Pancreas gets affected, and we get hyperglycemia and hyperglycemic emergencies. And also we know that patients who are obese, they have a worse outcome. So we'll first start with the hypothalamus pituitary adrenal axis. So to be honest, as of today, we don't have evidence, or we don't have data of the direct involvement of the pituitary or hypothalamic from the COVID-19 infection. But we do have we do have information from the data from the SARS COVID-1 epidemic during 2002, and that time it was shown that the hypothalamus pituitary axis can get affected, resulting in transient hypocortisolism. Again, the axis was involved either directly by the direct infection of the virus, involvement of the virus to the tissues, or indirectly to the autoimmune or inflammatory response. So this is a paper which was published in 2005, and this author, he tried to look at the survivors of SARS-1 infection, and then he showed that 41% of the patients after recovery from the SARS-1 infection, they had evidence of central hypocortisolism, and most of this patient, about 62% of the patients, this condition of central hypoadrenalism resolved over a period of 1 year. And also, we know that COVID-19 infection, we have a high rate of neurological involvement. The virus enters through the olfactory bulb, and it can cause anosmia and taste disturbances. So from this, we can hypothesize that the CNS can get involved, but we don't have exact data. Because this virus has 80% genetic similarity with the SARS-1 infection, we can assume that the patients with COVID-19 infection also can have similar manifestations as SARS-1. Then talking about the adrenal glands, again, during the SARS-1 infection, it was shown during the autopsy studies that there was a presence of adrenal necrosis, vasculitis of small veins of adrenal medulla, and infiltration of the adrenal gland with monocytes and lymphocytes, meaning that patients who are having a high inflammatory response, or patients who are in cytokine storm, that patients can develop acute adrenal crisis. Post-viral syndromes manifest as low energy levels, low mood and dizziness, and these have been associated with post-viral hypocortisolism, and they were dramatically improved with cortisol replacement. So this is again data coming from the SARS-1 infection. So in conclusion, we should be aware of these conditions, and we should keep in mind that the hypothalamus pituitary axis adrenal axis can get affected. And if the patients, either during the acute phase or during the recovery phase, if they have these symptoms, we should pick up these patients early and do the test and treat them accordingly. Next, we move on to the hypothalamus pituitary thyroid axis. Again, the thyroid gland expresses high level of ACE2 receptors. Again, the thyroid can get affected either directly or indirectly. And also during the cytokine storm, the thyroid can get inflamed. So this is just an overview how the thyroid can get affected. So either indirectly, either there is a direct virus infection or through the immune cells, and either the thyroid involvement is because of the hypothalamus or pituitary involvement, or the thyroid can be directly inflamed, leading to hypothyroidism. So the various manifestations of thyroid gland can be in the form of non-thyroidal illness. Patient can have thyrotoxicosis, either subacute, painless thyroiditis, thyroxine thyrotoxicosis, and Graves' disease, and hypothyroidism, which can be either central or primary. So the most common abnormality we see in sick patients is the sick euthyroid syndrome. This is biochemically shown as low T3, low or normal T4, and either normal or slightly low TSH, and increased levels of plasma reverse T3. This is because of the preferential conversion of T4 to reverse T3 during illness compared to T3. So these patients, so this is a paper coming from China, which in this they tried to look at the severity of the disease in association with the thyroid function abnormality. And what they have shown that if you look in this, the blue line is the number of patients who had a normal thyroid function, and the red line, these are the patients who had sick euthyroid syndrome. So the mortality or the proportion of severe patients or more sicker patients, so we see that as the thyroid function is disturbed, or the patient with sick thyroid syndrome, they have higher mortality or higher bad prognosis. So the conclusion of this study was euthyroid 6 syndrome was significantly associated with the disease severity and inflammatory parameters in COVID-19 patients. So again, sick euthyroid syndrome, the lower the T3 more severe the disease, there is a direct correlation between the severity of the disease and the level of the T3. Actually, this is not very unique to COVID-19 infection. Any severe illness, we see that patient can have this picture of sick euthyroid syndrome. So coming to the next part, the thyrotoxicosis, this is the first paper which was published showing that the COVID-19 can affect the thyroid. And this is a patient who was, this is a paper from Italy, and in this a young female who would have got infected with COVID-19, and she had a baseline normal thyroid function, and during the recovery phase she developed symptoms of hyperthyroidism, and it was shown that patient had a low TSH and a high free T4. And also if we look at the inflammatory markers were also high during this period. So the time the patient had abnormal thyroid function or subacute thyroiditis, at the same time the inflammatory markers, that is ESR and CRP, are high. And these patients during follow-up, subsequently the thyroid function normalized. So after this first report, there are many reports which reported the presence of subacute thyroiditis or silent thyroiditis in the patients either in the acute phase or during the recovery phase of COVID-19. Again, this is a single center retrospective study, and this they tried to evaluate thyroid function test and the level of interleukin 6 in 287 consecutive patients who were admitted to the hospital with COVID-19. And they found that about 20% of the patient had thyrotoxicosis, either subclinical or overt, and 5% patient had hypothyroidism, and about 74% had normal thyroid function. The conclusion from this study was that this study provides first evidence that COVID-19 may be associated with high risk of thyrotoxicosis in relationship with systemic immune activation induced by the SARS-CoV-2 infection. So here this is from the same paper, and if you look, that thyrotoxicosis was associated with higher interleukin-6 levels. So if you look here, these are on the y-axis, we have the interleukin level, and here we have the x-axis, we have the TSH level. So the lower the TSH, the higher was the interleukin level. So the lower the TSH, that is, if the TSH is suppressed, the higher was the interleukin level compared to the patients who had TSH in the normal range or in the higher range. Again, the in-hospital mortality was significantly lower in patients with TSH values in the reference range as compared to those with either with thyrotoxicosis or hyperthyroidism. So if you look here, patients who had TSH in the normal reference range, the mortality was lower compared to patients who had suppressed TSH or high TSH. Then the duration of hospitalization was also correlated with the suppressed TH. So if you look here, the patients who had a lower or suppressed TSH, they had the duration of hospitalization was longer compared to the patient who had TSH in the normal range or in the higher range. So yeah, so in conclusion, from this study, they tried to show that suppressed TSH or thyrotoxicosis, either subclinical or overt, was related to higher inflammatory markers, a longer duration of hospital stay, and also higher mortality. Also, there are case reports showing that COVID-19 could be a trigger for new onset or relapse of Graves' disease. There is one case report wherein the patient was in remission from Graves' disease for 20 years, and once he's got the COVID, there was a relapse of Graves' disease. And we end with the thyroid and reproductive axis. So we know that men have a higher susceptibility to the virus infection, and also they have worse outcomes and deaths compared to women. And we'll try to look into it, why this happens. And as we already discussed, that this virus enters the body through the ACE2 receptors, but we need the cleavage of the spike protein by this host transmembrane protein series 2. This is the enzyme which helps in the cleavage of the S1, the protein S, and then it facilitates the entry of this virus into the cells. So this protein is regulated by androgens. So this protein is higher in men compared to the women, and this may be the reason that men are highly susceptible and the outcome is worse compared to women. So these ACE2 receptors are actually the testis is a high-risk organ vulnerable to the SARS-2 infection, and the ACE2 receptors, they are not only expressed in the spermatogonia, but they are also seen in the Sertoli cells and the Leydig cells. And there is also shown that there is a destruction of seminiferous tubules and reduced spermatozoa from immune-mediated orchitis. Actually, there are many case reports showing that the only manifestation of COVID-19 infection was orchitis. And this shows that patients can have impaired spermatogenesis and androgen synthesis because of the involvement of the Leydig cells and the spermatogonia. So this can result in male hypogonadism and subfertility. So what we need is after recovery from the acute infection, we need to follow up these patients for hypogonadism and subfertility, and definitely we need further studies to assess hypogonadism and spermatogenesis following recovery from the acute illness. We have some questions like, can SARS-CoV-2 infection lead to gonadal dysfunction or fertile potential loss? Are those changes reversible after disease recovery? So the answer is we don't know yet, and we need further prospective studies following recovery from the acute illness to answer these two questions. So coming to the female reproductive axis, actually the ACE2 receptors are present in oocytes, ovary, uterus, but till now we don't have data on the female gonadal or reproductive dysfunction. And actually the estrogens seem to have a protective effect against this virus, and also estrogens are protective against the happening of cytokine storm. So with this, I move on to the most important COVID-19 and diabetes mellitus. I will spend a little more time on this because diabetes is the most common metabolic or endocrine disease associated with COVID-19 infection. So COVID-19, it appears to precipitate severe manifestations of diabetes, including DKA, hyperosmolar state, and severe insulin resistance. And severe insulin resistance was reported in many cases, and patients who were controlled with oral hypoglycemic drugs at home, they can present with the diabetic emergency and requiring very high doses of insulin, reaching up to 20 units because of the presence of severe insulin, 20 units per hour because of the presence of severe insulin resistance. So the mortality in patients who have diabetes and COVID is 3 times compared to the patients who don't have diabetes. So there is an increased risk of morbidity and mortality if the patient has diabetes and then gets COVID infection. The same is with hypertension and obesity. So this is a meta-analysis which was recently published, and they looked at 30 studies. Most of these studies either were observational or retrospective studies, and more than 6,000 patients. And the conclusion of this study was DM was associated with mortality, severe COVID-19, ARDS, and disease progression. So this is a very crowded slide, but I'll just try to tell you the important points here. And the mortality, the severe COVID infection, and ARDS and ICU care and disease progression all were high in patients with diabetes patients compared to non-diabetic patients. So how hyperglycemia causes worse outcome? So because we know that hyperglycemia has harmful effect on innate immunity, including dysfunction of phagocytosis, cell-mediated immunity, and neutrophil chemotaxis. And the pancreas can, the beta cells can get affected because the islet cells, they express high level of ACE2 receptors, and also hyperglycemia, it causes glycosylation of not only the ACE2 receptors, but also the viral spike protein. And both of these, it facilitates the entry of virus into the host cells. And apart from direct beta cell damage, there can be alterations in the self-antigens of islet cells or the beta cells, and subsequently these beta cells can be damaged by immune-mediated destruction. And these patients can have, in future, they can have immune-mediated diabetes, for which we should be on lookout. Additionally, there can be involvement of the exocrine pancreas, and because of the inflammation of the surrounding exocrine pancreas, there can be a bystander beta cell death, leading to insulin deficiency. So we have many questions. These are the questions we'll try to answer in the subsequent slides. So I'll go through one by one. The first question is presence of diabetes associated to a high risk of COVID-19 infection? So the answer is logically thinking or theoretically speaking, yes, we think that diabetic patients, because they are immunocompromised, they should be at high risk of contracting COVID-19, but we don't, the answer is still unknown, and the data coming from various studies showed that the diabetic patients as such, they are not at high risk to contract COVID, but once they get COVID infection, they have a worse outcome. So this is the data coming from various countries, so we have conflicting data. So these are the ones in blue, they are the hospitalized patients, and this is the general population. So the hospitalized patients and the general population, the prevalence of diabetes is almost similar in China and Italy. If you see the number of patients with diabetes admitted to hospital with COVID, or in the general population, the COVID patients, it was the same prevalence, but the number of patients with COVID and diabetes was high in USA and Spain. So we don't have a clear-cut data, but in general, it's the opinion of many authors is that diabetes as such is not the diabetics don't get the infection, but once they get the infection, the prognosis is bad. So this is the opinion of this author. The prevalence of diabetes among people affected by COVID-19 is not higher than that observed in the general population, suggesting that diabetes doesn't increase the risk of SARS-CoV-2 infection, but can worsen the outcome of the disease. So do type 1 have the same risk as type 2? So to answer this question, this is the big study coming. This is the Cornada study. This is coming from France. Here they tried to look at the charts of about 68 national centers, all diabetic patients. They reviewed the files and they found that the conclusion of this study was, in conclusion, among patients with diabetes requiring hospitalization for COVID-19, the present data suggest a lower risk of severe prognosis in those with type 1, especially the younger ones. So again, we are talking about only hospitalized patients, so we don't know what's going on in the community. So mostly what we have seen during our experience in this hospital, that most of the type 1s, when they presented with diabetic emergencies, but with treatment, they recovered. One factor why the type 1 don't have that much worse prognosis is maybe because they are young, and also type 2 patients, not only they are older in age group, but also they have other comorbidities like hypertension, obesity, NASH, obstructive sleep apnea. All these are the factors which are making these patients for a poorer outcome. So does hyperglycemia play a role in progression to severe illness? The answer is yes. So these are the possible mechanism why hyperglycemia makes the prognosis worse. So we already told that it causes glycosylation of estrogen receptors and also protein, S protein, facilitating the viral entry. Second, the elevated blood glucose level also causes increased blood glucose level in the airway secretion, which increases the virus infection and replication in the pulmonary epithelial cells. These patients with hyperglycemia, they have impaired immune and inflammatory response, and it also affects the pulmonary function, and the inflammatory markers are higher in patients who are hyperglycemic at the time of admission compared to normal glycemic patients. And also hyperglycemia in patients with and without diabetes can also have a negative impact on the efficacy of COVID-19 therapy, especially tocilizumab. It's shown that patients who are hyperglycemic, the effect of this drug is not as much as compared to patients who is normoglycemic. Also, it's another important point is the glycemic variability is also associated with the worse outcomes. So we need to maintain blood glucose level in a certain target level. So if there is hypos and hyper, the outcome is poorer. So in this study, the author, they tried to show that the inflammatory markers are higher in patients who are hyperglycemic. So if you look at the left-hand panel, these are the normoglycemic patients, and this is the interleukin levels on the y-axis. So basal level, week 1, week 2, these are the interleukin levels. These are the normoglycemic patients. These are the hyperglycemic, and we can see that throughout the basal, week 1, week 2, the interleukin levels are higher in hyperglycemic patient compared to the patients who have a normal glucose level. Similarly, with the D-dimer, the patients who have hyperglycemia, the levels are higher throughout week 1, week 2 compared to the patients who have normal blood glucose level. Again, there was a direct correlation which was shown with the glucose at admission with the level of inflammatory markers. So the higher the glucose at the time of admission, the higher is the level of interleukin 6 and higher is the level of D-dimer 1. Again, in this study, the author tried to show that the inflammatory markers can be brought down by good control of blood glucose by giving IV insulin infusion. So these are the patients who did not receive insulin, and these are the patients received insulin infusion. So these are the patients who did not receive the insulin infusion. So this is the interleukin 6 level. And if you see the patients who received IV insulin infusion, the inflammatory markers are markedly dropped down during week 1 and week 2. And same is the with the D-dimer, again, if the patient is put on IV insulin infusion earlier, the markers have come down rapidly compared to patients who were not treated with infusion. So the conclusion of this study was that optimal glycemic control during hospitalization is associated with reduction of inflammatory markers, and we can think of a good outcome if we control the blood sugars very well. So again, this is another study which shows that patients who are having hyperglycemia at the admission is associated with severe prognosis. So the line in green is the patients who are normoglycemic. The line in red is the patients who are known diabetics, and the purple line is the people who are not known diabetics, but they develop hyperglycemia at the time of admission. So if you see, the worst outcome is seen in patients who are not known diabetic and they develop hyperglycemia at admission. So the mortality was highest in the hyperglycemic group without diabetes, 39%, versus patients with diabetes. They had non-diabetic, they have a mortality of 29%, and normoglycemic patients, they had a mortality of 17%. So with this, we come to the conclusion that hyperglycemia was a strong independent predictor of mortality. And these observations suggest that controlling hyperglycemia from the time of hospitalization might reduce progression to severe illness or death, even for people who are not known to be diabetic. Now, coming to the question, does pre-admission glycemic control or HbA1c alter disease outcome? Or we also want to know what are the pre-admission factors related to diabetes which are associated with worse outcome. So to answer these questions, this is a retrospective study from US, and here the author, they tried to look at about more than 1,000 patients hospitalized with diabetes and COVID infection, and 33% of them died. And what they found is this is the age group, and the blue line is the male patients and the red is the female, and this is the BMI here. So the conclusion was, in all age groups, male patients and with higher BMI, they have the worse outcome. And as the age increases from age 20 to 29, from either to 60 to 69 or 70 to 79, the mortality is higher with increasing age, increasing BMI, and male sex. And in this study, they found surprisingly that HbA1c level at the time of admission or within 3 years prior to admission was not associated with mortality, but any outpatient insulin regime, like patient was already on insulin prior to admission, that had a stronger predictive value for mortality. So again, in this, we just try to see that the glucose control at admission is very important for the outcome of the disease. Pre-admission factors are the associated comorbidities like hypertension, obesity, obstructive sleep apnea, NASH. These are the comorbidities with the worse admission, and associated complications of diabetes also predict poorer outcome according to this particular study. So the clinical guidelines recommend maintaining glucose levels between 140 and 180 for most critically ill patients, and more stringent levels of 110 to 140 may be reasonable if we can achieve this without causing significant hypoglycemia. Insulin should be the treatment of choice for critically ill patients with COVID-19, and to achieve glycemic targets, IV insulin infusion is the best, and for patients who are more stable, we can put them on basal bolus insulin regime as standard of care in the non-critical setting. And another important factor is the frequent glucose monitoring. In these patients, we don't want to expose the staff to the patient because frequent glucose check needs frequent contact with the patient. So prevent this we can use some newer technologies like continuous glucose monitoring, which shows a continuous level of glucose in the interstitial fluid, and that can be used. So FDA has recently approved the use of both Freestyle Libre and Dexhome for inpatient use during the COVID-19 healthcare crisis in non-critically ill patients, but not in the patients who are critically ill, hypertensive, or in ICU. And both these systems can securely transmit glucose measurement data to digitally connected devices. So we can have a look at these glucose levels without going to the patient frequently and checking their blood sugars. So in this hospital, we have available Freestyle Libre, and we can use this. And also the FDA also approved that in stable patients and in the ward setting, patients can bring their own home glucometer, and they can check on their own and then communicate the readings to the healthcare workers caring for them. So this is just a summary of pre-existing diabetes and COVID-19, how best to treat them. So again, inpatient insulin is the best treatment, but very, very selected patients who are very stable in the ward, we can continue with the oral medications like sulfonylureas, meglitinides, and DDP4, but SGLT2 inhibitors should be stopped because of the risk of euglycemic decay. But as an outpatient, again, it's advisable to either they can use oral drugs if they are stable and they are not having nausea, vomiting. But again, they need frequent glucose check, and they should be educated and counseled about the sick day rule because of the change in the oral intake and because of the disease, they can be changed in the requirement of these medications. So with this, we end with the diabetes and COVID. Now we'll just talk about vitamin D. As we have seen in this pandemic, that there is some data coming from the European countries that they have a higher rate of mortality and higher rate of sick patients because they also have very low vitamin D levels. And again, countries in the northern latitude showed higher risk of mortality, higher morbidity compared to the countries in the southern latitude. And although the data are very inconclusive, but it's good if you ensure that all the patients have an adequate vitamin D level. So vitamin D, it has a role in the immune mechanisms, and it enhances both the innate and the cellular immunity. And what we see that there are vitamin D receptors in the dendritic cells and macrophages, and actually we have this 1-alpha hydroxylase enzyme present in the both the macrophages and dendritic cells, and it converts the 25 hydroxy vitamin D to 125 hydroxy vitamin D, and this binds to the vitamin D receptors. So once the virus enters the body, this enzyme gets activated, and then we have an availability of the active vitamin D. And this active vitamin D, what it does, it causes viral clearance, increase phagocytosis, and also it decreases the replication of the virus. So it has a protective effect against these viral infections. And also there are some proteins in the body which gets produced once there is a availability of 125 hydroxy vitamin D in the cell, like cathecillidine and defensins, which blocks the viral entry and suppresses viral replication. So, and also vitamin D is shown to be having an immunomodulatory action, and it presents excessive stimulation of the adaptive immune system and thus prevents cytokine storm. And the Endocrine Society recommends supplementation with 1,000 to 4,000 international units of vitamin D, and to maintain a serum vitamin D level of more than 30 nanogram is recommended. So now we talk about the parathyroid gland. So till as of today, we don't have data either for the expression of the ACE2 receptors, viral invasion, or inflammation of the parathyroid glands. or either alteration of the parathyroid hormone level or calcium homeostasis during coronavirus infection. But we have unpublished data suggesting a possible association between hypocalcemia and COVID-19 disease severity and prognosis. Actually, in general, we see that we do see hypocalcemia and severe critically ill patients. So maybe this is part of the severe illness. So we don't have really good quality data to tell that this hypocalcemia is associated to COVID-19 only. So this is just a chart like pre-existing endocrine condition, how best to treat during the COVID-19 infection. So most of the diseases, pre-existing diseases, they don't require much change in the treatment. Hyperprolactinemia, they don't need any change in the dosing. Cushing's, the same treatment, but if they need to be worked up, they should be postponed. And patient with hypothyroidism, no dose adjustment needed. Hyperthyroidism, no dose adjustment needed, but we should be aware of one of the rare side effects of anti-thyroid medication, that is agranulocytosis. So the symptoms of agranulocytosis can overlap with COVID-19. So if the patient develops fever, sore throat, we advise the patient to stop the medication, anti-thyroid medication for 1 week and check the CBC. And coming to hypoparathyroidism, we should ensure that this patient have adequate calcium and vitamin D, active vitamin D tablets available, because we know that hypocalcemia causes prolongation of QT interval, and some of the drugs which are being used for COVID-19 infection, like hydroxychloroquine and azithromycin, also can prolong the QT, leading to arrhythmias. We did talk about vitamin D hypogonadism. Testosterone, the same dose can be given, or even discontinuation for some time. It's not, it can be done. Estrogens, if possible, from oral to transdermal should be changed because of the, to lower the thrombosis risk. Now I'll talk a little bit about hypoadrenalism and COVID. So patients who are known to have adrenal insufficiency, we need to increase their dose. And the recommendation is, this is just an expert opinion, that the patient need to improve the hydrocortisone dose to 20 milligram every 6 hours in order to provide evenly spaced physiological glucocorticoid coverage for the persistent acute inflammation and often continuous fever experienced by the patient with COVID-19. And if the patient is on prednisolone, we should split the dose morning and evening, 10 milligram in the morning, 10 in the evening. If the patient comes with adrenal crisis, we should give 100 milligram IV stat injection, then followed by, it's better to give an infusion rather than giving every 6 hourly or 8 hourly. It's better to give a hydrocortisone 200 milligram infusion over 24 hours. And we need not change the dose of fluorocortisone. Coming to diabetes insipidus and COVID-19 infection, it's very, these patients, if they are not able to take orally, we should change the treatment to either a spray or injectable form of desmopressin. And also these patients are at high, they are susceptible to develop hyponatremia if the dose is higher. So, and we cannot go for electrolyte testing frequently. And one opinion is to omit the tablet for 1 day per week to encourage the practice of once a week aquaresis by omitting 1 dose of vasopressin, so to prevent against development of hyponatremia. And so with this, I come to the end of my lecture. So we'll just go through the important points. COVID-19 can affect various endocrine organs, either during acute phase or recovery phase, due to the presence of ACE2 receptors in various endocrine organs. Diabetes mellitus is the commonest comorbidity with high mortality and morbidity, and good glycemic control at hospital admission may improve the outcome. Hypocortisolism may be a sequelae of COVID-19 due to HPA axis involvement, so we should be aware of that. And if the patient comes back with the symptoms of dizziness, low mood, low energy, we should check for adrenal insufficiency and treat accordingly. Thyroid abnormalities are common, and low TH is associated with high inflammatory markers and poorer outcome. Low vitamin D, again, is associated with poor prognosis and susceptibility to cytokine storm, and male reproductive axis can be involved and needs follow-up. With this, I come to the end of my talk. Thank you very much for listening, and very happy to answer any questions.
Thank you, Dr. Anja, for this really extensive work, extensive research. I mean, you make it mostly as best evidence talk. As you said, I think each organ or endocrine organ can be its own lecture to talk about COVID. So now the floor is open for Q&A, or if they want to talk also, we can allow for the audience to share opinion or to ask question. Dr.
Yes, doctor.
I mean, you know, now there is, I mean, maybe one of the evidence of medication, dexamethasone, in critically ill patient, mainly respiratory issues. So what's your comment about who's being diabetic to start dexamethasone? You know, the colleague, they will be anxious for glycemic control, putting patient in dexa 6 milligram, which is more than 12 times requirement.
Yes, thanks for your question, doctor. Like, yes, definitely the introduction of steroids to the therapeutic regime, definitely it increases worsens the glycemic control. So we do need to act proactively and adjust the insulin doses. So actually our department, we did have a protocol for patients who are put on steroids. So we need to increase the doses by 20 to 30% and frequent monitoring. And if the patients are really uncontrolled, the blood sugar is persistently more than 300 or 350, it's better to start them on IV insulin infusion. But we do have a protocol for patients who are COVID positive and on dexamethasone available.
Perfect. I think because of time, I mean, people will go to see their patient and to start their clinic. I think this is already been already in YouTube. Even the people or other colleagues, they can ask question later on and even can be answered kindly by Dr. Anjum. So I think we can finish our lecture or talk today. Any comment from the continuous education department?
Yes, please, just make sure to do the evaluation after the lecture.
Okay. Thank you, Ms. Basma. Thank you all people. Thank you, Anjum.
Thank you.
Hope to see you by next week by another talk from Prince Sultan, Military Medical City, Riyadh, Kingdom of Saudi Arabia. Thank you.
Thank you very much, sir. Thank you.